Good evening, everybody. I welcome you all on behalf of my other faculties for this particular meeting in which we are going to discuss 5 complex cases. Along with me, we have got expert as a Murli Mohan sir, who is a respected name in ILD care in India. We have got Prabhu Desai sir, whose clinical acumen brings very sharp perspective for all the discussions. We have got Rajan sir, who is a trusted senior, like a mentor to me and thought leader. Mithun, who is known for his keen interest and keen diagnostic skills as well as inputs. Our radiology expert today is Vimal Raj sir, and whose interpretation always elevates our understanding of our ILD cases. So we have 5 challenging cases and without lined up with diagnostic as well as therapeutic dilemma. Let us begin as always. May our collective wisdom bring some improvement in the patient management, like always. There are 3 cases from my side. There is one case from Dr. Padmanabh Shinoy, which will be presented by Dr. Riji. And we have got a last case by Dr. Rajan sir. So I'll start sharing my screen. So the first case is 67 years old man who is from Kollam, and he's ex-serviceman. Now he has diagnosis of interstitial lung disease with SLE for lupus hepatitis and oral lichen planus. He was being treated in my hospital for last 10 years. Suddenly he came to me once again because his complaint of intermittent episode of cough has been increased, and he denied of any shortness of breath, chest pain or hemoptysis. So he first visited to me somewhere in 2016 or something. Uh, by the time he was already diagnosed as ILD and lupus, but he was not under regular care, and he presented once again. That is how the history is. His saturation on room air was 94% when I examined him with BP and other vitals stable. When I auscultated him, he has bilateral velcro crepitation. These are his investigations, and he had ANA 2 plus cytoplasmic. ESR was 107. Creatinine was 3.52, which is expected in lupus nephritis. CRP was 83. So CRP, ESR were high. And he's under follow-up Dr. Mithun, and he's under follow-up of gastromedicine as well as nephrology department for his lupus-related problem. And I think this is his ANA profile. Mithun, your inputs will be appreciated.
Actually, this is the new NA profile, no?
Yeah, new. The thing which I had sent, yeah.
What was the previous ANA profile? I think
ANA and
slightly.
DSDNA, yeah. ANA and DSDNA. DNA positive, yeah. That was what.
Previously, I think DSDNA was positive. And this is the new one because his SLE disease appears to be in remission for a long time. Therefore, it's possible that this antibody intensity will come down or antibody titer will come down. Okay. Here the anti-SSA is positive. We have to take it as significant because on treatment, no? On treatment.
Yes, he is on treatment with elevated ESR and CRP, yeah.
Elevated ESR and CRP this time due to some infection, no? I feel it's due to infection. His
maybe
CRP was almost normal for the last few years.
Sure.
And
so,
this is SLE on treatment, and this antibody titers are low because of the treatment. And his DSDNA was previously positive.
Yeah,
with this report, we cannot say that patient is having Sjogren or anything. Because patient is a non-case of SLE. Okay. And this is the latest ANA profile. That's all.
Yeah, that's it. Okay. So the reason I had sent it was maybe if we will see the CT scan, we will have more idea. And about myositis also, Mithun, if you can just say.
Myositis, non-specific, multiple antibodies are positive in low titers. That's all.
So it's not significant. And this is his over the years spirometry and DLCO and other investigations. As you can see, overall status quo FE1 upon FVC as well as the ratio. And surprisingly, even DLCO is not decreased. but RV by TLC was 37-39%. There was no desaturation. He covered 420 meters. But sorry, on the last time, to 2025, he desaturated from 98 to 91%, but he still walked 420 meters. So he has some desaturation this visit, but most of the times his physiological functions were very good. And with that, I will stop sharing my screen and over to Vimal Raj, sir.
Okay.
Yes,
So
sir.
very interestingly, this is one patient we have images dating as far back as 2016. And this is his imaging from 2016. I'll start off with this. At that time, not much in terms of lymph nodes. The pulmonary artery is also normal in caliber. And if we see the lung parenchyma at that point in time in 2016, we're just seeing these subtle areas of ground glass abnormalities in the subpleural aspect of the lungs. There's this one periphyseal nodule. This is something very constant all along. And upper parts of the lungs were very clear. Then if you fast forward it to 2023, what we can see is we started to see subpleural changes, more ground glass, lesser of reticulation in the upper lobes. And as we keep going down, you will start to see more and more of ground glass. Some subpleural cystic changes have started to come in. Traction dilatation of bronchi is already settled, and diffuse areas of ground glass consolidation with some cystic changes. Bronchocentric disease, but extending all the way out to the periphery. This was in 2023. Now, the most recent scan, this is from May 2025. If we see the subpleural changes are persisting, increasing, some small subpleural cysts are there. And as we come further down, you will start to see that disease has really progressed, more fibrosis, and we're starting to see areas of honeycombing now settling in the lungs bilaterally. So if I just put all of these together, you will see that this is from 2016, 2022, 23, and this is the most recent 2025. You can see along from the right middle lobe to right lingula and the lower lobes, we can see these areas of fibrosis worsening over a period of time where there was nothing much to begin with. And then both my active disease is also there. There's some components of pure ground glass and then some components of fibrosis also. So this is fibrotic interstitial lung disease. The current pattern actually is that of UIP pattern, but CTD ILD is what one would think about in here.
And you feel that 2023 to 2025, there is a significant progression, sir, right?
There is, yes, that's correct.
Okay. I'll share my screen once again. So that's what I also felt. He's currently on Azoran 50 milligram 200. And my questions to the panel was, first question was to Mithun that I already asked him when I saw the patient that how commonly we see ILD in SLE, because that is something which is rare for me. At least I can have inputs from Rajan sir and Prabhu Desai sir and Murli Mohan sir, whether like SLE is something which is ILD is very uncommon. That is the first question. And in patient with SLE associated ILD or overlap syndrome, if that's what this is, do we add on some mycophenolate, or are you happy with Azoran, Mithun? Do you want to add upon something? He's 64 and he has got kidney problems with creatinine of 3.4. And Vimal Raj sir, is there a radiological or functional progression, which he already said? And this is for panel, that should we add upon nintedanib? Is there any role? With that, should I stop sharing my screen or you need questions?
See, ma'am, an ILD in SLE is actually not as common as other CTDs.
Yes.
However, but we see ILDs, especially if there is a associated autoantibodies like UNRNP and in overlap syndromes also,
Yeah.
especially with scleroderma overlaps. And regarding the drug of choice, there is a progression of disease while on azathioprine. Definitely, we need to change the drug
Even
either to
kidney involvement MMF is better, right, Mithun?
kidney, MO, azathioprine, both are good. But if for the lung point of view, we need to escalate the modification drug to mycophenolate. Mycophenolate is safe in CKD.
Yeah. I think Mithun has addressed now to our panel, Prabhu sir and
Yeah.
Rajan sir. Yeah.
Uh, what Dr. Mithun said is absolutely right. I mean, we don't see much lupus, but in practice, when we see so many lupus patients here, at least I can say that we see lung involvement. Not only that acute lupus pneumonia, but even fibrosis is seen, even organizing pneumonia pattern is seen. Okay, and but it is the per se lupus coming to us and practice is much lesser for a lung point of view. So that way, I can say that how many lupus patients we see, not much actually. So
Yeah.
of course, I'm thinking that they are not referred for us, but we
Sure.
don't know whether we are missing lung disease in lupus. Okay, because now this patient, his X-ray will be absolutely normal. I can tell you. So unless you do the scan, okay, we will not come to know. So I don't think we should have a fair idea about lupus and lung involvement because we don't
Yeah.
do routinely scans because rheumatologists are how many
Okay.
rheumatologists are doing scan nowadays they started doing scans in the unless they are breathlessness is there, so maybe some subtle features of interstitial disease in lupus may be missed, lupus overlap, lupus vascular disease if it is there, that also we probably maybe maybe there, so there's some shadows will come, but I know in this patient I would like to say that surprisingly, the lung involvement is significant, if you see. But the lung function test is really not real. Even the 2023 and 2025 lung function shows hardly any deterioration.
Yes, sir.
There is honeycombing is seen. So I am of the opinion definitely either on we should stop, we should change something. But why not add antifibrotic here? Because there is a bronchiectasis, there is a subpleural fibrosis, and though it's no radiology pulmonary function test point of view worsening, radiological worsening is there, and in fact this probably antifibrotic adding in the early stage may help. This is I thought.
So the problem here, na sir, he had lupus hepatitis and
Okay.
lupus nephritis. So
Okay.
I believe that is also happening, right, Mithun? He had
Yes,
hepatitis and he had
hepatitis.
nephritis.
But
So
is there any chronic liver disease?
He has
he has
chronic liver disease.
he has
Okay.
chronic liver
So
disease. So that's the another problem. Yeah, Rajan sir.
So, Asmita, the two things here. One is that the incidence of ILD in lupus is not common. And I agree, it's probably around 5%.
Okay, sir.
Less, in some reports, 2 to 3% actually. I agree with Mithun and Prahlad that we need to change the drug. And I think that should be the first thing to be done. Because the moment you keep if you have to make a change, your question was, should you escalate to mycophenolate? Mycophenolate is not more potent than
parallel, yeah.
azathioprine. Yeah. It's probably a little safer. So you could switch to mycophenolate without having any high expectations. The key issue I would ask, and that I would like to ask Mithun, is whether we should consider rituximab before starting an antifibrotic. There seems to be honeycombing developing as per what Vimal said. So yes, it is tempting to start an antifibrotic, but he has chronic liver disease. So there are a lot of things that you need to discuss. Very interesting to have so much longitudinal data. He's lost about 10% vital capacity in 10 years, which is very minimal. So I'm not sure if we should rush into the antifibrotic, but just see if we can gain something. And I'm not sure if we're going to gain much more with Myco versus trying harder, considering he's 67 with rituximab before he gets too old and it becomes more risky. What do you feel, Mithun?
So in SLE, basically there are some head-to-head trials between all these medications. But basically for lupus nephritis, we have ARMS trial, mycophenolate versus azathioprine, where they found that mycophenolate was superior in controlling lupus nephritis. Therefore, in SLE, we consider mycophenolate as superior, although this data is only on lupus nephritis. And
Sure.
rituximab issue is that most of the trials actually fail in SLE, but still we are using it as an add-on therapy like mycophenolate plus rituximab, not a monotherapy in lupus nephritis. Therefore,
Right.
when you are giving a rituximab in SLE patients, usually we combine with mycophenolate mofetil.
Okay. So probably switch to myco, and then
Decide on if patient still progressing, then rituximab.
Rituximab, and if that also fails, get on the antifibrotic, because you'll have to do it sequentially rather than combine upfront two new drugs. Because
Correct.
if you start mycophenolate and the antifibrotic together, Smita, he develops hepatotoxicity, you will not know which one is the cause.
Sure.
I would do it sequentially rather than up.
Everything sequentially. And do you agree, sir, that pirfenidone also will be okay choice if I have reservation for nintedanib?
Absolutely.
Okay.
Yeah.
Okay. Yeah. I think that is fine, and we will move on to the next case. 1 second. So if Murli Mohan sir has joined, or I will go to the next case and then we will go to the third case.
I've joined, Dr. Smita.
Okay, yeah. Thank you, sir. So this is another, this is slightly simple case and we'll finish it fast. That mostly Vimalraj sir's input itself will be sufficient. So this 75 years old man who is retired banker, and he came to me he has been diagnosed as obstructive airway disease for 5 years, never smoker, but he has recurrent exacerbation, 3 hospitalizations, September 24, January 25 and May 2025. And then in June also he had an exacerbation which was treated on OPD basis. He has systemic hypertension and diastolic heart failure. Seizure disorder, subacute hemorrhage 30 years before, and phenobarbital. Skin disease treated in 2018, which not very significantly known, but most probably not related to CTD to the best, like what I can think of. And presented with grade 3 dyspnea, fever and cough, which was taken care of because of exacerbation. He has exposure to rubber sheet. Now in Kerala, this rubber is in your backyard. So most of the people we ask, and some people actually handle the rubber. So he has been exposed to rubber sheet smoke for more than 10 years. That's what they are saying. And there is a pet animal dog. No family history of asthma or anything. Overall vitals were stable. IG is greater than 2500. Aspergillus fumigatus was moderately positive IgG, and specific IG was also positive. IgG, when the cutoff is 11, he had 16.3. This is his spirometry and lung volume and DLCO. As you can see, FEV1 was 25% of predicted, ratio of 44, DLCO of 34, and KCO of 45. Total lung capacity was 3.27. Then walk test, he didn't desaturate, but he didn't walk either. It is 180 meters, that's what he walked. Echo was suboptimal window, but no RWMA, good biventricular function, no pulmonary hypertension, no vegetations and all. And with that, I will stop sharing the screen.
Whenever somebody says it will be easy, I always worry. In there. So this is the CT scan of this gentleman. This is from earlier this month. A couple of things where there's a lot of atherosclerotic changes in the aorta, which is okay for his age. Not much in terms of lymph nodes that we can see. Small amount of pericardial effusion is present. What is interesting is in his kidneys, we can see these multiple cysts in these kidneys. And some of these are hemorrhagic cysts, especially in the left kidney. There are multiple cysts, and some of them have had hemorrhage within them. Right kidney has got this large cyst, and we really can't see the kidney at all. When we look at the lung parenchyma, I'll start from the top. He struggled to hold his breath, but what we can see at the top very clear is that there's a lot of emphysema. There's a lot of breathing artifacts also. There's centrilobular emphysema. that we can see. You can see all these central dot sign that we keep talking about. And then as we come into the lower lobes, there is all these larger areas of coalition of these changes. I am not seeing any distinct cystic lung disease within this. There is a lot of hyperinflation. I'm not seeing any major nodule or mass lesion. There's a lot of bronchial wall thickening within this. To me, this looks significant emphysema. The only thing, if at all, other things fit in, I would consider is whether these have gone into a bizarre shaped cysts where one would think about Langerhans cell histiocytosis. But my initial thought is that this is all emphysema, and I am not fully convinced about any other cystic lung disease within this.
Okay. I think we will move to my question. My doubt was only that is this cystic lung disease, or I'm treating him as a COPD, and is the CT pattern consistent with pure emphysema, RBILD, or is it cystic ILD? So you feel that it is favor of emphysema, right? Pen,
That's right.
SNR, centriness, everything.
Yeah.
And like if it is not cyst, then there is no point of asking cyst uniform or peribronchial or anything, right? And you feel that the kidney cysts are totally not related to the lung.
Yeah, these are not the standard Burthock-Dubé or any of those renal cysts that we're seeing. He's got probably chronic kidney disease of one form or the other,
Okay.
where there is multiple hemorrhagic cysts within that.
Yeah, and I did not send any CTD workup because my first diagnosis was also COPD. Does the panel feel the same way, or should I investigate further? I didn't send it. That's what I have done, and because if there is no is this HP pattern by anyhow? Because he had significant rubber sheet exposure, so HP can have cystic pattern.
HP can definitely have cystic pattern, but then you would expect other things also in a disease with HP, where if cystic, it's fully cystic.
Okay.
It's not HP either.
Yeah, so your radiological diagnosis fits into emphysema, and if panel also agrees with that, we can have a consensus diagnosis.
Absolutely. I think that's COPD.
Yeah, so no need to send any further investigation. Rajan sir, Prabhu Desai
Yeah,
sir,
I know.
right?
What's his echo? Pulmonary artery pressures. His KCO was also quite low.
They didn't. It was done outside. What I have written is in that the pulmonary hypertension was not mentioned, sir. He didn't walk actually 180 meters. That's what his exercise tolerance is. Yeah. So maybe he needs long-term oxygen on if exertional dyspnea or exertional desaturation is present.
He's not desaturating on walking, from what I could see on your lung.
No. What he did is he walked only 180 meters. So we don't know, sir. That is the thing. Yeah.
So I'm just wondering whether his exercise capacity is limited by the pulmonary.
Okay, sure. So I will have to have a look on pulmonary hypertension on echo report, which is not mentioned in the current report. Okay.
Vimalraj, I would like to ask you now in this patient, if you see predominantly central lobular emphysema, right? No, and some of them bizarre. And we see many times paraseptal emphysema and some heterogeneous emphysema sometime. So is there something like that we can differentiate the probably etiology of emphysema from here compared to
We can.
Hypersensitivity pneumonia gives cyst, but they are cystic lung. Their interbreathing lung is alveolitis. Here there is no, it's an emphysema.
Yeah, so in this case, around the apex, there is some paraseptal disease, which is not differentiating. What we talk about is emphysema versus other cause of emphysema, like alpha-1 antitrypsin talks about distribution of disease, which helps us in differentiating. Otherwise, when we are looking at this, it is a pan-lobar emphysema or pan-acinar emphysema that we are seeing because the lower lobes is diffusely destroyed with that. HP, I would, as you exactly said, cysts with intervening alveoli, intervening normal lung, which I'm not seeing in here. Correct. So,
Ant has put some comments in the chat box that ABPA in COPD, absolute eosinophil count. So yes, eosinophil counts were not to the amount of ABPA, but it was around 2 to 3% of total count, which was 6 to 7,000. And IG of greater than 2,500. Definitely, we have to treat it as a asthma rather than COPD in this. But the CT scan is matching with them, so it's very very, as sir told, it is not easy case to deal as a pulmonologist. Anyway, we'll move on to the third case, which is even more interesting, I believe. And this is again the patient. Like the beauty of Amrita is we are seeing patient. This is a boy of 21 years old. Why I'm telling boy, because I still remember when I saw him first time in 2013. That was the time when I saw him, and he is now 21 years old, and he came to see me after 2016 was his last follow up. After some 5-7 years, he has come to see me, and he has history of TAP VC at the 5 days of his age. That was not done at our hospital. However, he was under follow-up of pediatric cardiology of my hospital. And I vaccinated him when I saw him. And then he's getting treated by Dr. Supriya at the periphery. So with that history, now he came to me because suddenly he has started developing recurrent infection, recurrent hemoptysis. First time also when I saw him, he had recurrent hemoptysis. And that time I checked him for immunoglobulin deficiency, but he didn't have any. And that time there was 2016 CT scan, the films of which I do not have, was labeled as a bronchiectasis, right middle lobe and left side. This time we have a CT scan images, which Vimalraj sir will just show to you people. His saturation was 96%. Left sided crepitation is what I found at present. Right side normal vesicular breath sounds, nothing else. I sent alpha 1 antitrypsin this visit because I wanted to rule out any other congenital causes. He already had congenital heart disease, but that is normal limit. ESR, CRP, everything is normal. He doesn't have any significant infection. He came just for second opinion because I saw him when he was young. And this is his serial spirometry, which was done over 2013, 2015, 18, and 2025, which is this visit. His vital capacity is 66%, FE1 83%, which actually gradually improved over a time. Maybe because he performed it better. Now he's 21. And no desaturation, covered 480 meters. There is a recent echo which was done in May 2025, no pulmonary hypertension. His RVSP plus RAP was around 31 plus RAP. Yeah, 31 plus RAP. That is what his pressures were. No systolic or diastolic dysfunction. I'll stop sharing my screen and circuit.
Okay, so to start off with, I think it's important to see the chest X-ray of this child, where you can see that there is loss of volume in the left hemithorax compared to the right side. There has been prior sternotomy. Few interesting things. So the man has underwent TAPVC, total anomalous pulmonary venous connection repair. What you will straight away see is that the loss of volume in the left lung. See the right pulmonary artery, the size of the right pulmonary artery, and see the size of the left pulmonary artery. Left pulmonary artery is much smaller in comparison to the right side. The other very interesting thing in this is when we look, I'll just show it to you. These are the pulmonary veins on the right. This is a large pulmonary vein. This is the middle lobe pulmonary vein, and this is the right lower lobar pulmonary vein, all going into the left atrium. Left side, this is the pulmonary vein. Just that one tiny thing that you can see here. This is the pulmonary vein, which is draining the left upper lobe. There is no left lower lobe pulmonary vein. So the left lower lobe pulmonary vein is diffusely hypoplastic, occluded with multiple collaterals in the mediastinum at that level. And this is a delayed phase as well. So one would expect the pulmonary veins to be filled by that. When we look at the lung parenchyma, what you will see here as I come from the top, you start to see this interlobular septal thickening. in the left lung, and then there are these subpleural cystic changes that we can see, especially only in the left lung, not much. And there is all these increased interstitial changes that we can see with some loss of volume, and you can see these cysts again. The right lung is pretty much clear. We don't see too many changes, and there are all these septal thickening towards the periphery of the left lung and few isolated cysts here and there. So this is something we have often seen in children who have unilateral pulmonary atresia or unilateral pulmonary hypoplasia, where you tend to see this subpleural areas of cystic changes with loss of volume. This is essentially pulmonary venous occlusion in this child with interstitial changes, but more of subpleural cystic changes and septal thickening. And right lung is clear.
Yeah.
Vimal, are there collaterals too?
So there are venous collaterals and some arterial collaterals. So we can see some of the collaterals coming all the way from bottom celiac axis. These are the arterial collaterals. If you keep seeing this, they kind of come along the diaphragm and are supplying the lungs. And these small ones here, we don't have an arterial face to clearly delineate them, but these are all small collaterals which are actually supplying the job of the venous and arteries.
So my doubt is, sir, usually we see this hypoplastic lung when there is a pulmonary artery which is rudimentary. So if pulmonary vein is rudimentary, then also the lung won't develop. Is it the same way, or is it different?
I really don't know the answer to that question. Murli with is working in an institute where a lot of these corrections
No,
are
even
done.
Vimal's answer also. So they both have to answer our queries. Like, how do you find out? First of all, my thing was not that the reason I put is only one. I felt there was a fibrosis, subpleural honeycombing kind of thing, or one layer of cyst. But why it is only localized to the left lung? And I didn't know that the hypoplastic lung we had seen without fibrosis, but this child has developed almost like fibrotic lung. So only hypoplasia itself can cause, matlab the lack of blood supply can cause this much of fibrosis. That I'm seeing for the first time. Like maybe my ignorance, but I'm seeing for the first time. So
we have published a few cases with exactly the same, where unilateral or unilobar reduction in blood flow gives you this cystic lung disease kind of an appearance.
okay.
In this, the disease process is usually pulmonary venous occlusion, leads to pulmonary hypertension, leads to reduced pulmonary arterial flow, and then the pulmonary arteries go down over a period of time. And
Okay.
that leads to reduction in the flow. So it's a vicious cycle which happens.
So
And I
there
think
is
what
no.
we're seeing quite nicely is the smooth interlobular septal thickening here. Very
Yeah.
typical of, and it's
Very-
unilateral PVOD as it were.
Yeah.
So
Yes.
can you explain that once more, Vimal? I'm sorry, I didn't get you. So you're saying reduction in pulmonary venous flow causes increase in pulmonary artery pressure.
Yeah.
Okay.
Within the lung. So the
Right.
pressures in that lung are so high that the pulmonary arterial supply to it also goes down.
So it's like a post-capillary pulmonary hypertension.
But he has not developed it yet, because I saw that specifically. I actually read about this step VC and all. And I was thinking it is a pulmonary artery narrowing which is causing hypoplasia. And I was thinking if I will dilate the pulmonary artery, which can be done, right? Murlimon sir, we can do balloon angioplasty and all for pulmonary artery. But what about vein? If vein is narrowed, you can't do anything, right?
Yeah, even the artery is not easy to do because it's a fairly thin-walled artery. So
Okay.
I think in our institution, I know we've done it only a couple of times, and none of the vascular surgeons or the cardiac surgeons or the cardiologists are enthusiastic about doing it.
Okay. So I was planning to have a visit for RKK sir, but you feel it won't work, right? So
the changes have already occurred. I'm not sure we're going to achieve very much.
But will it progress? Like you are just seeing one layer of cyst now, and then it will progress. And he's only 21. That's why I feel little bit worried about him, because he's only 21 and he has long way to go. Otherwise, very healthy child. Like he was planning to go abroad, and that's why the mother brought him to me, telling that is he fit enough to travel, kind of.
They usually progress. The pulmonary veins, even the surgeons can't do anything. If it's a focal area of stenosis, fair enough. But in this case, the pulmonary veins are just gone. So any intervention you do to the pulmonary artery is temporary because the veins are gone. So it will not help.
So it's futile. Now, my second doubt is, usually when the hypoplasia and all these things happens without fibrosis, the pulmonary artery is not working and the other lung is working and they do well. So whether this child, this man, matlab now child or man, whatever, he will do well overall. What do we expect, sir? Because if it was not fibrosis, will the pulmonary hypertension not happen? Or it will still happen, because that is not functioning lung. What we expect is autopneumonectomy, isn't it? That lung should get died and nothing should happen, and the right lung will be enough for him to live. Will it happen like that, or will he become more sick day by day?
So it's very interesting when you have a unilateral pulmonary artery agenesis. Those are the people who end up with a huge number of problems. And if you do a pneumonectomy on one side, they don't end up with pulmonary hypertension.
Yeah.
It's very strange, that relationship between them. We've had patients with unilateral pulmonary artery agenesis go to a high altitude, develop severe pulmonary edema, come back, and they're really sick. Whereas, as you said, you do a pneumonectomy and nothing really seems to happen. It's like the body is, once you've got the lung out with the arteries, the remaining lung takes over and they manage perfectly well. So the pulmonary hypertension in this chap has not yet developed, isn't it?
Not yet.
So
Not yet.
Pulmonary hypertension in his case will probably refer only to his left lung. So overall, with the autopneumonectomy, he'll probably do quite well. And we have to hope that those lesions, one of those cystic lesions, doesn't burst and he ends up with a pneumothorax. That's the only thing I'm worried about, honestly.
Murli, sometimes this very nice case, like in macularoid syndrome, how you get bronchiectasis and pulmonary artery hypoplasia, and these people are many times asymptomatic also, unless they get so. And echo also doesn't really shows many times pulmonary hypertension in this patient. So hypodevelopment of the say agenesis or partial genesis of the lung also gives hypoplasia. So it's what exactly is the vessel which gives lung problem, or lung disease gives the vessel issues. So that's another thing which thought. And second thing is that which is worth doing a ventilation perfusion scan to see what exactly is happening to the lung.
The first part of it, I don't know. Whether it's the the artery that gives rise to the lung problem or vice versa. I suspect both of them develop, the artery and the lung develop simultaneously and the connection occurs later. So I suspect it's the arterial hypoplasia that leads to the lung hypoplasia, but I'm not sure about that. The second part, interesting. I think it's certainly, from an academic point of view, it's certainly worth doing a ventilation perfusion scan to see what's happening. Vimal, would a dual energy CT give us similar information?
Probably not, because what tends to happen in here is the venous structure is what is there. So the two runs that we do, that may help us. How is the initial run arterial flow and the second run, which is the venous flow, certainly. So that would give us an information of distribution of.
And MR, QS, QP, will that give us the difference?
That definitely will tell us what is the distribution. And I suspect more than likely that he's already developed left lung pH. I think he'll have a unilateral pH already there.
Vimal, we have not seen many veno-occlusive disorders. So is this probably a unilateral veno-occlusive disease? And is the bilateral, means the veno-occlusive disease, the scan will look like this?
Okay. So when we say PVOD, the veno-occlusive disease, which is the actual, idiopathic congenital kind of a thing, that will have usually will not have a focal area of involvement.
Okay.
This is behaving like PVOD because there is definitely venous occlusion. Images will look exactly what you're seeing in the left lung. You will see septal thickening. When you start to see PH patients with good septal thickening, that's the first thing that we start to think, is this PVOD in these patients? So septal thickening is very, very classical in PH to suggest that it's PVOD.
Okay. And in this patient, X-ray chest shows a prominent pulmonary artery conus. What exactly is that if there is no pulmonary hypertension?
The pulmonary artery, because what is happening is that the heart is actually shifted to the left side. So it is making it more prominent.
Actually, I agree with Prahlad. Murli, that our macleodes do pretty well. I mean, they remain stable for quite some years. And this really looks like a unilateral PVOD. If you look at it, I don't know if that's ever been reported after TAPVC correction, And you need to probably do a literacy. What is your cardiologist saying about his
I
prognosis?
just had a word with him before we had this discussion, and he was like, he asked me specifically. I was confused whether the pulmonary artery, because I saw the CT scan and I could not identify the pulmonary veins, but pulmonary artery was narrowed, and my diagnosis was hypoplastic lung secondary to rudimentary pulmonary. I thought it is a congenital rudimentary pulmonary artery, not secondary to what Vimalraj sir just explained. And my explanation to him was that. Usually, it should cause venous occlusion post surgery. If it is related to artery, he can help me out. And he told me to have another look. He has to have a look on the artery by himself. That is what he told us. So maybe he was planning for right heart catheterization or something like that. Will it help, Murli Mohan sir? What do you say? Like, I'm talking about Shine. Yeah, Shine was the one whom I discussed.
I think
Vimal,
it would help.
because I think you will be able to demonstrate the differential pressures on both lungs, both the pulmonary arterial and the if you can wedge it and get a reflection of the pulmonary venous pressures. But is it going to change your management? I'm not sure.
Okay. Sure. Okay. So is that all? We'll move on to the next case.
Yeah,
We can't do.
Yeah. Sujit, when you have a hypoplastic artery, you're not going to go through this sequence of events because the inflow is also low. So
that's right. That is true.
It will be more simple, right? It will not be this complicated. Yeah. Okay. So we will move on. Let me see if Dr. Riji is there.
Yes. Good evening, ma'am.
Yeah, 1 second. I'll just share. So I have changed few of your slides. So we have this particular discussion is not about seminar kind of thing, only case and queries. So those flow chart and all which were not relevant, I have put it in the last. Okay. So I have taken some freedom to change your some slides. So all yours. Yeah.
Okay. Good evening, ma'am. Good evening, sirs. Thank you for this opportunity. So I would like to discuss this case of a 47-year-old lady whose complaint started as a dry cough, which was progressive with a history of exposure to pigeons and paper dust for almost 1 year prior to onset of these symptoms around 2021. And after that, due to this progressive cough and followed by mild dyspnea on exertion, initially only MMRC1, she was evaluated elsewhere where a CT thorax was taken, which showed some interstitial thickening, peribronchiovascular location, and with the bronchiectasis with an impression of ILD. And she was treated there. And at the time, her blood workup showed a rheumatoid factor positive, but ACP negative. ANA was not very significant, ANA profile. And HSP panel showed multiple antibodies positive, namely Aspergillus fumicatus, Alternaria alternate, Cladosporium herbarium, Penicillium chrysogenium, and PGM serum protein as well. So based on this, she was started on some oral antibiotics with methylprednisolone, slowly tapered along with bronchodilators, but she didn't have much improvement. She continued to have cough. And then she consulted another pulmonologist. A repeat CT was taken in March 2023, which this is available for discussion today, and which showed the report came as suggestive of organizing pneumonia bar HSP. At the time, she had elevated acute phase reactants, ESR 91, echo normal. Along with the tapering dose of glucocorticoids, she was tried on HCQS also, and then MMF was introduced. After optimizing MMF to 360 TID, she says that she was symptomatically feeling better, but we don't have a documented PFT during this period. And the repeat CT taken several months later in September 2023 showed progression, but the same line of treatment was continued. And towards the end of the year, because she was feeling symptomatically better, she stopped everything and moved on to alternative system of medicine. And then by a few months later, again, cough restarted. And the dyspnea on exertion now started to worsen from grade 1 to grade 4. And she started having regular chest pain over the left side with some radiation. And then her oxygen saturation began to fall. And that's the time that is between, this happened between December and July. And by July 2024, last year, she consulted us. So at the time, she presented with dependent edema, but no history of any PND or any cardiac dyspnea. TB workup we did was negative. MANTO, even QTB was negative. Clinically, no other domains of a connective tissue disorder, no constitutional symptoms, and no past history of tuberculosis or asthma or diabetes. And on examination, bilateral diffuse coarse crepitations were there, and then 6-minute walk she didn't tolerate. There was desaturation. And ma'am, next slide, ma'am. And routine investigations were all normal. ESR was this time, it was relatively normal. She had stopped all the medications about 6 months back itself. X-ray showed diffuse heterogeneous opacity is bilateral. Rheumatoid factor again came to be positive. But all the other autoimmune workup, ACP, MP, or myositis profile was negative. ACE in serum calcium was also normal. So we went ahead with the repeat CT in July 2024, which hopefully Sir will discuss. And after that, we decided that because there is a progression of a disease, we decided to start her on cyclophosphamide.
Okay, let us show.
Okay, ma'am.
Yeah, you are muted, sir.
I've got two images. One is from July 2024, and unfortunately, the patient has been extremely breathless all along the exam.
Yes, sir. Yes, sir. Yes, sir.
And this is the mediastinal window in July 2024. Not seeing much in terms of any major lymph nodes. The esophagus is patulous. There's a small hiatus hernia. And when we look at the lung parenchyma at that point in time, what we are seeing are these large areas of abnormality, which is bronchocentric, very difficult to comment on. So let's just see. This is the other, again, July, and here it's much better imaging. And what you can see is bronchocentric areas. There is interstitial thickening, which is quite abnormally thickened with traction dilatation of bronchi. Some irregular nodular outline is what I feel with these interstitial thickening that you can see. Upper lobe is involved, mid zones are involved. There is traction dilatation of bronchi. And as we come lower down into the lung basis, again, there are these areas of involvement with traction dilatation of bronchi, bronchocentric consolidations with some cysts in the left lower lobe. This is July 2024. And then when we move on to December 2024, we can see similar pattern in the upper lobes, traction bronchiectasis, bronchocentric disease, few cysts here and there, which are being split out. And you can see traction dilatation of bronchi, patchy ground glass, same cystic changes. Fissures, if you actually see very minor nodularity, not too widespread nodularity, then some other areas, you can see the thickening and nodularity. There's some conglomeration of nodules here. We can see focal nodules in the right lower lobe and some end-stage fibrotic changes across. Mosaic attenuation is there, definitely. And as we come, extreme lung bases are spared. And again, here you can see the fissure is looking a little too nodular. So widespread interstitial process, bronchocentric in distribution, end stages of fibrosis, focal areas of air trapping. To me, the first thing I would consider is a sarcoid in this. The second one would be a hypersensitivity pneumonitis. I'm not able to tell much about the lymph nodes because of the breathing, but in here you can see some lymph nodes are there, not too chunky, but those would be my two top differential diagnoses. And between the two scans, not much of a difference.
Yeah.
No scans of this year?
It was
Yes,
July.
sir.
No scans of this year?
We last CT, sir, was taken on last December 2024. That was the last one, sir.
Sure.
Okay, 1 second. I'll just share the screen. So they did yeah, go ahead.
And we also got the impression of a chronic pulmonary sarcoidosis. So we decided to go ahead with a PET scan, but there were no FDG avid lymph nodes, and but there was definitely an ILD. So we advised lung biopsy to the patient, but she was not willing. And but in spite of having a negative autoimmune workup, and because she had a good response to immunosuppression in the past, we decided to proceed with immunosuppression and started her on cyclophosphamide. So at the time she was on oxygen supplementation at home. So we started on 1 milligram per kg prednisolone equivalent of glucocorticoids along with cyclophosphamide. First 3 doses, we slowly hiked. And after 5 doses, still no symptomatic improvement. Cortimoxazole prophylaxis she didn't tolerate. And that is when the second CT was taken. And after that, we in fact did not change our line of treatment. We continued with cyclophosphamide itself. And by May, 2 months back, a cumulative dose of 6 grams of cyclophosphamide was given, but still there was no improvement. And from February onwards, because there was significant fibrosis also, we started her on nintedanib as well. Up to 250 milligrams, she tolerated. After that, she doesn't tolerate. She develops loose stool. So on 250 milligram of nintedanib and cyclophosphamide and low-dose glucocorticoids, she continues to worsen. She is dependent on LTOT. Since last month, she requires 4 liters of O2 as opposed to 2 liters earlier. And her bloods, however, all look normal except for the ESR and CRP, which now is persistently elevated. And also last 2 months, we have not been able to give cyclophosphamide because she gets recurrent LRT as well. So this is the current situation. So our query is, can we try, is there any benefit in any other immunosuppression, or should we again press for a lung biopsy? Is lung transplantation an option for her? Or should we rethink diagnosis?
I think if she's not agreeing to a lung biopsy, she's not going to agree for a lung transplant.
Yes, sir. Yes, sir.
She has stopped picking up our phone calls now. I don't think she's going to come back.
Sujit, suppose she agrees for lung biopsy. Is she a candidate for lung biopsy? Not at all. I think she will.
But Shenoy, why didn't you pulse her? Any reason you didn't want to pulse her with steroid?
Because we gave 1 mg per. See, our now current thinking in rheumatology is moving away from pulse. Pulses don't add much. That is the current thinking everywhere. Sure. Even in ANCA-associated vasculitis, also people say pulse doesn't have much role, just increases mortality. So we gave her 1 mg per kg, and it did not improve. She didn't show any improvement at all. She is continuing to worsen.
Okay. Oh, so you gave her methyl
1 milligram per
pulses or cyclo?
No, we gave her cyclophosphamide pulses with 1 milligram per kilogram, 45 milligram, 50 milligram of per day steroids.
Okay.
But see, Sujit, my observation is that this sort of a pattern, peribronchovascular thickening, these are all dangerous patients. They worsen very fast compared to the chronic HP patient. They deteriorate also very fast. And this sort of patient has got a really poor outcome. This sort of a fibrosis pattern. Okay, here hardly a honeycombing is seen extensively, like an IPF, obviously honeycombed lung. Here very, very minimal, scanty honeycombing. Vimal, is there any something sort of pleural thickening? Is it a pleuropulmonary fibroelastosis pattern, especially in apex?
See, the problem is it's there everywhere. And when we look at the apices in particular, let me just go back and see that.
And Lakshmikant has brought up a point while Vimal draws up those images that if this is some unusual type of malignancy, Shenoy, then she's contraindicated for transplant. So without a biopsy, there's no question of listing for transplant. I
I don't
think,
think she'll be willing. I don't think she'll be willing for a transplant. Very unlikely.
right.
Only thing was whether it's a definite sarcoid. Probably we can give a try anti-TNF and see. That was the only thought process we had. Maybe adalimumab or infliximab. We can, but diagnosis again, if it is not definitive, whether we are wise enough to do that.
And what gain you will achieve on 4 liters oxygen already at rest? Her requirements
Yes,
are.
yes.
What's her blood gas like? PCO2?
I don't
PCO2, sir.
remember.
Last admission PCO2 was 45, sir.
45. It's
Already CO2 retention.
it's already going up.
So the PET scan did not suggest any malignancy. The chances are that we're dealing with a fibrotic lung disease.
Yes.
She's young. She's walked, 45 meters in her 6-minute walk test. I would be pushing for a lung transplant. I mean, obviously you can't force her, but if she is, if she can be persuaded, I would go for a lung transplant straight away. I think the chance that we're dealing with a malignancy is extremely small. And I think actually Lakshmikant's point was, if biopsy is mandated, then only do it. Otherwise,
Possibly, yeah. It doesn't look like a BAC. I agree with you, Murli. It doesn't look like a BAC, but she's obviously sitting on the fence on a biopsy. So I can understand why she's not taking calls now. She's probably pretty sick.
Dr. Prahlad, no pleural thickening at the apex.
Okay, fine. Thank you.
Yeah.
So the other question I had for the panel is, people do the serum calcium. Should we do that, or should we do a 24-hour urinary calcium? Because that's more specific for sarcoid. Dr. Shenoy, what is your opinion?
24-hour calcium is more specific, no doubt about it. But it happens when even the ACE levels are not very high. So what happens in fibrotic phase, I'm not sure really whether we will get something from there. Very unlikely we will get. It's not a very active disease. Probably it's a burnt out disease. That's why she is not responding to any of this.
The PET didn't show much uptake or anything, Shenoy. So it's very unlikely to be active. And that's probably is the reason she's not responded to immunomodulation already.
Yes.
Which means that I don't think adalimumab will work either.
Yes. So I think it is the end of the story, most probably. We'll tell her to transplant, which she may not probably agree.
Yeah.
And probably pulmonary rehab is the only thing which will help her.
Absolutely.
No, but she never received methotrexate, na, Shenoy?
With so much fiber, such a low lung capacity, giving methotrexate, so really
They are scared of the fibrosis. Okay.
Not fibrosis, pneumonitis. Even if they have some pneumonitis, then you are confused whether it's a pneumonitis or infection. That's why.
Yeah, because nothing. Sorry.
Thank you. No worries. Thank you.
Okay.
No worries.
Yeah.
Thank you. Thank you, sir.
Asmita, before you share the next case, let me share this screen. This was the case report that I was talking about.
Yes, sir.
This is unilateral agenesis of a pulmonary artery, where you can see that RPA is fully absent, and you can see the cystic lung disease in the right lungs and nothing on the left lung.
Oh, yeah. There is no right pulmonary artery as we can see here. And it was congenital. It was not like TAP VC. I thought because the surgery was done, that has complicated the matter. If it was by birth, it would not have happened. So it's not like that. Even in congenital, it happens. Okay.
Yeah, in congenital, you have the artery which has the problem. It's usually not the vein. The venous ones are post-op.
Okay. But even congenital artery stenosis or rudimentary congenital artery can cause the similar changes which happened in the current patient. So it has nothing to do with post-operative or iatrogenic or nothing like that. The process is same for everybody. Okay. Oh, this is what you published. Wow.
Yeah.
And interestingly, there's a lot of mosaic perfusion on the other side.
Yeah, he has. So it's common. Yeah, I'll just share the last case, which is from Rajan sir.
Yeah. This last case especially wanted Mithun's input here.
Yeah, 1 second.
This is an elderly lady, homemaker, married with 2 children, hypertensive, diabetic, and hypothyroid. And she's been complaining of exertional dyspnea, but only on long walks, no cough, no autoimmune symptoms, and goes for half an hour evening walks every day, slowly at the pace she's comfortable with, no past TB. Saturations are good on room air. Diabetes slightly out of control. Good echo. And she was treated with inhaled steroid with LABA and theophylline for the last 1 year. Hemoglobin 12.2, ANA by IF negative, P ANCA was 1 in 20. The myocyte is blot. Her PL7 showed up a 3+. And that's my question actually when Vimal pulls up the scans. HP panel negative, C3 was normal, CRP was okay, ESR okay, CCP negative. Next slide. And that's the blot. The myocyte is blot. And since Shenoy is also there, Shenoy can also give his inputs if he's listening in. And this is our lung function. Last year to this year, there is no, there's a slight increase actually. Good, I mean, some reversibility, 10% in 150 ml. That's why I think she was put on all these inhalers. I stopped all the theophylline and all that. Her DLCO wasn't done last year. This year we did it 51%. And a 6-minute walk test was pretty decent for her age, 312, 98 going down, not going down, BOG 0 to 1. So, Vimal.
So this is the CT scan of the 75-year-old female. Starting with the mediastinum, mild atherosclerotic changes in keeping with age. There is some coronary artery calcification, so some degree of coronary artery disease is there. Nothing else apart from simple cysts in the kidney. When we look at the lung parenchyma, if we start from the top, what we can see is the interstitial changes starting to come towards the periphery of the lungs. All these are showing reticular changes, very, very subtle early. And then as we come more towards base, you get to see more and more changes. Traction dilatation of bronchi has started to set in. You can see here in the right middle lobe, lingula, reticulation. As we come further down, mild mosaicism is there in the lungs, and towards the extreme lung base, you get to start to see these early layers of honeycombing which have started to form. And so towards the extreme lung bases, we can see honeycombing has started to settle. And there is no telltale signs of a dilated esophagus or too much of lymph nodes. The pulmonary artery size is also within normal limits. So what we are dealing with, and when we do prone imaging also, we can see that this is not dependent change. You can see very clearly that there is this honeycombing which is well established in these regions. And on expiratory imaging, there is mosaic changes that we can easily see in the lungs diffusely. So from a pattern point of view, this is a fibrotic ILD, and definitely it is going more towards a UIP pattern, but it's not that typical of an IPF. There's a lot of bronchocentric disease. For me, CTD versus hypersensitivity pneumonitis would be the two differential diagnoses. Within the two of them, CTD is more higher in the list compared to HP.
So hardly symptomatic, and that's the thing. If you go back to a lung function, Asmita, so yes, there's air trapping there, and it's a UIP-like pattern, which is what our CT radiologists reported. But with all that air trapping, Prahlad, if you can see, the ratio is not like severe airway disease. Neither are the lung volumes significantly compromised. She's 76, I think, right, Asmita? 76, yeah. Right. So what would be my question was really what next to do? I mean, her complaints aren't much, but this PL7 has suddenly come up. So should I give her mycophenolate and she's diabetic and hypertensive. And as Shenoy said, everyone's drifting away from steroids, so I don't want to risk a steroid trial at her age. But because she's hardly symptomatic, so
these antibodies, these are anti-synthetase antibodies. No? Sometimes even in unrelated patients also we see this JO1 strong positivity and EPL7 strong positivity. Basically, if there are no symptoms, then it's actually difficult to give weightage to this antibody. But is there any muscle weakness or mechanics hand?
she walks half an hour a day, so no muscle weakness at all. She's quite well otherwise. The only thing is, if she has to walk for a little longer, she's a little out of breath. And she walks half an hour every day otherwise. So I think it's the CT and the report that is concerning me more than the patient, to be honest. So I was concerned about the antibody, and then Bhavin report signed off saying UIP-like pattern. So I was wondering, now do I have to give an antifibrotic? We don't have longitudinal scans, right, Vimal? No. So just keep under observation, Prahlad. What do you think?
I think so. She's doing quite okay. I was impressed by that prone images. It gives so beautiful picture, right? And
Yeah.
I would like to ask Vimal, we generally ask prone images when there is when we have some subpleural density.
Basal, yes.
But does it adds to your scan if you do routinely subpleural, like in this patient?
Yeah, it basically, in the terms of diagnostic information, it adds definitely, because what tends to happen is if we look at some changes in subpleural aspect and we think it's severe disease or severe fibrosis, when we prone it, the congestive component comes off it, and it becomes much more clear, and it looks much lesser and clearer in that. The technical challenge and doing it is a different aspect. Yeah.
Also, Prahlad, you will find out that when your radiologist doesn't get good breath hold, they're able to hold their breath a little better in prone.
Correct.
And so you get good images in prone.
Yeah.
Of course, the other thing is to do a caudal to cranial direction of doing your scan. If they can't hold their breath too long. So at least you get the bases very clearly.
Okay.
Absolutely.
So, but I would agree with you, Sujit. For me, it is, the old watchful expectancy, masterly inactivity for this patient.
So,
every 6 months you do
get her cardiac checked more.
But what would be our working diagnosis? Because Asmita needs a working diagnosis on every case. So would it be IPF, or would this be anti-synthetase, CTD-ILD, anti-synthetase syndrome? Should we label it that, Mithun? Would that be?
And I think it's difficult to label it as anti-synthetase.
Okay.
Unclassified.
But that will be a better term, or undifferentiated or unclassified.
Yeah, and at this age, I don't want to biopsy her either. Even though her lung function is good for biopsy, I don't think I would recommend it. The risk outweighs the benefit.
But you need to follow up, I think.
Yes, we will follow up closely. Thank you.
Okay.
Shenoy found it tough. I think he escaped. Joking.
Great.
Asmita, you're muted.
We can't hear you, Asmita. No, we can't hear. But anyway, I'll close the meeting. Thank you, everyone. Thank you, Murli. Thank you, Vimal, Prahlad, and Mithun, really. And of course, Asmita, whom we'll hear enough in the next time. Yeah, the date next time is July. The date for next time, I think we have a earlier meeting.
Can you hear me now?
We can hear you. Yes.
So we have 4th July meeting this time, and then we will have on 18th July. So please reschedule your appointments accordingly, because 4th July, and then we have PG update coming up on 13th July. That's why. 11th July, sorry. So 4th July is the next meeting.
So
we will have 5 cases. Yeah.
Next week, Friday.
Next week, Friday. Thank you so much.
Thank you.
Thank you all.
And surprisingly, whenever Bhavin sir is not there, we finish fast, isn't it?
Bye.
Bye.
Bye bye.